I am Dr. Paul Leger. I'm a medical oncologist at MedStar Georgetown University Hospital. I take care of patients with genitourinary cancers, meaning patients with prostate cancer, kidney cancer, bladder cancer, and testicular cancer. I also take care of patients with gynecologic cancers, which include uterine cancer, ovarian cancer, and cervical cancers. For me, the most important is to provide the best possible treatment to my patients. And the other thing that's very important for me is to have my patients involved in their treatment decisions. I usually like to take quite a bit of time with my patients to go over their diagnosis, review all possible treatment options, to educate them. Because there, I think that they're more involved in their care and they understand what's going on. I'm so excited about the opportunity to make a positive impact, a positive difference in the life of my patients. I love when I get into the clinic and I enter the room and start with some good news to tell them how well their treatment is doing. I like to pick up the phone and call them at the end of the day to let them know, for example, that their PSA is being very low or being undetectable. I think that's the most gratifying or rewarding thing for us in this field. And that's what keeps me going. So I do believe that there is a great advantages for patients to come to MedStar Georgetown because we do take care of our patients and we really care about them. And we also have the teamwork where we have multidisciplinary team of experts working all together. We have medical oncologists, we have radiation oncologists, we have urologists, the surgeons, and we have radiologists and pathologists, all of these teams working together. We hold weekly or bi-weekly team meetings to go over these patients with more complicated situations to figure out the best way to treat them. I think it's a great advantage for our patients. So a medical oncologist is, usually in medicine we think of medicine like internal medicine or surgery. So internal medicine, we take care of the entire body, all the organ system, compared to the surgeon who do surgery to just cut, for example. So a medical oncologist is initially an internal medicine doctor who did some additional studies to become a specialist in treating cancer. So we basically treat cancer, but the medical aspect of treating cancer, because you can also treat cancer with surgery, but we do not do surgery, but we do systemic therapies like chemotherapy and this kind of treatment. Most of my research is more focused on prostate cancer, but also as a GU oncologist, I treat patients with kidney cancer, bladder cancer, and testicular cancer. Those are what we call genitourinary cancers. Many of my patients ask me if they can find different treatment other than hormonal therapy for their disease. Unfortunately, the backbone of the treatment, for example, of advanced prostate cancer, consists to suppress the testosterone level because testosterone is the hormone that feeds the cancer. The best way that we know to treat this cancer is through suppressing the testosterone level with hormonal therapy. For patients with very early stage disease or patients with very localized disease, we may treat them with surgery. And in that case, we may not need to do the hormone therapy, but basically for patients with more advanced disease or high-risk disease, even when they are treated with radiation therapy, they do need to receive hormone therapy. Unfortunately, when we suppress the testosterone, this is the equivalent of what we can call a castration. When you suppress the testosterone, we'll obviously have side effects such as patient will have a decrease on their sex drive, what we call libido, or they will have erectile dysfunction. Some of them will feel hot flushes like a woman going through menopause. Also, they will feel a little bit more tired or have some weakness, and some of them may lose their muscle mass or the bone mass as well. Those are the most common side effects you would expect with hormonal therapy. Patient on hormonal therapy who has a good response to hormonal therapy still need to go through radiation therapy, because the standard treatment for localized prostate cancer is either surgery or radiation. When we do radiation, we usually associate it with hormone therapy. So even when they respond well to hormone therapy initially, they still need to go and have their radiation therapy. For patients, for example, who receive time-limited treatment for the disease, particularly when we treat them with hormonal therapy and radiation therapy, when we stop treatment, we would expect that they may improve the side effects, particularly for the libido and for their erectile dysfunction. However, I would like to caution patients that they may also have side effects from the radiation on their erectile function. And also the other thing is that these hormone therapies, they had a long half-life, meaning that this treatment will still be active in the blood even when we discontinue treatment. So it may take time before they can feel any significant improvement. Some of my patients taking hormone therapy, they feel weak, they feel tired, and they experiment as well this decreased libido and their sexual drive. They tend to think that maybe taking some testosterone supplement could help. But actually, this is very counterproductive, because this is exactly what we want to do. We want to suppress their testosterone. So we cannot recommend them to take supplements. It's very counterproductive, and it's not helping at all. Surgery and radiation therapy are considered to be equally effective to treat localized prostate cancer. Sometimes we base the decision on some characteristics, some aggressiveness, the level of extension of the disease. And for some patients, we give them the choice, because both are equally effective. And in that case, patient may choose which one do they prefer. For metastatic prostate cancer, the first thing is that this is basically palliative treatment, meaning that we can no longer cure the disease, and they need to be treated with either chemotherapy or new hormonal therapy. For patients, chemotherapy and hormone therapy can be equally effective, particularly for patients with what we call high volume disease. And in this case, we base our decision on toxicity profile and level of tolerance. Metastatic prostate cancer, we can no longer cure those cancers, and those patients should be treated for as long as they tolerate the treatment and they benefit from the treatment. Usually, most of the treatment regimen will work very well for a year or two, and then after that, we will need to switch to a different regimen. But the good news is that we have many different options to choose from. I also treat gynecologic cancers. That means ovarian cancer, uterine cancer, and cervical cancer. And for that, I work with the gynec team to develop like a treatment plan, and I'm taking care of the medical aspect of this treatment because some of them may require surgery as well, and the gynec team will take care of the surgery. So the multidisciplinary care team means that we have different specialists working together to provide the best possible treatment for our patients. In the case of prostate cancer, we have medical oncologists, radiation oncologist, surgeon, the urologist, radiologist, and pathologist, all of us working together to come up with the best treatment plan. And this is definitely a very, very effective way to treat our patients and offer them the best possible treatment. These days, I'm particularly focused on research on prostate cancer. I'm interested in looking into health disparities and working into better understanding how can we address, how can we promote health equity to address disparities, but in prostate cancer. And also, how can we make sure that all of these wonderful progresses that we have, how can we make sure that everyone, everywhere, and at all time can benefit from this progress? I also interested in research to discover new tools to earlier and better diagnosis, new tools for risk stratification and prognosis, but also new treatment. We definitely need more treatment options to prolong the life of our patients, and also more tolerated treatment to minimize side effects on them. I believe that participating in clinical trial is the best way to help us move forward and to promote like discovery, innovation, and do better in terms of treating our patients. In fact, there is no way we can make progress without having volunteers into these clinical trials. And what I would like to remind my patients is that participating in clinical trial does not mean necessarily that the participant will directly benefit from those trials, but at least they will allow us to gather more knowledge, more information, so that we can treat better other patients. And these other patients may be their family, their friends, their loved one, and the community in general. So the best way for patients to figure out if they are eligible is to talk to their doctor or talk to the team in charge of the clinical trial to figure out if they meet the criteria, if they're eligible for these studies. Often they may need to do additional testing to make sure that those patients meet the requirement of those studies. Participating in clinical trial, I believe, is a way for patients sometimes to have access to even better treatment, definitely. However, I would say as well that participants should be aware that participating does not necessarily mean that they will directly benefit from those treatments. However, we would always gather new information to help us treat better other patients and move our knowledge on how to do better. The NCI-designated comprehensive cancer centers are academic institutions of excellence who have the scientific background and standard to develop very high-level clinical trials and provide excellent care to their patients as well as training. So having care at those institutions usually will give you access to better treatment, better care, and higher standard of care, and access as well to clinical trials. And MedStar Georgetown is one of the NCI-designated comprehensive cancer centers. So MedStar Georgetown is an NCI-designated comprehensive cancer center. I believe that one strong reason for patients to consider coming to MedStar Georgetown is because we do care about those patients. We really care about them. And the other reason is that we have the teamwork, the multidisciplinary team approach, where all of our experts work together to come up with the best treatment plans for our patients. Definitely, I would encourage patients to come and receive care at our center.